Hello, everyone. Thank you for joining us today. For those of you who don't know me, I am Dr. Lee Sanders. I'm a professor in pediatrics and health policy and chief of the Division of General Pediatrics, as well as a member of the advisory board for the HEAL Network. In an effort to build support and community among faculty who are interested in health equity, Stanford Medicine's Office of Faculty Development and Diversity hosts a number of health equity, action, and leadership or HEAL network events throughout the academic year. The HEAL network goal is to highlight the work of Stanford Medicine's health equity researchers and their personal journeys into their research area through a webinar series in collaboration with the Stanford Center for Continuing Medical Education. We should have a slide up on the screen for you in a second that provides some information about how to obtain that CME credit. Otherwise, reach out to us separately. Today, I would like to welcome all of those of you who are joining us remotely for today's HEAL webinar on Techquity, or Technology Equity in Healthcare. Today's webinar will feature 3 brief presentations from our phenomenal panelists and will be followed by a Q&A. If you have questions throughout the presentations, we request that you place those questions via the Q&A feature at the bottom of your Zoom screen. Panelists may respond to your questions directly in the Q&A feature, or we may allow them to respond verbally during the Q&A segment of this presentation. I'm now going to introduce you to the first of our 3 speakers. Choi is clinical assistant professor in the Division of General Pediatrics, where he attends on the newborn nursery service. And in our clinic, he also leads our pediatric digital health initiatives for the division and is a member of the Techquity Coalition for Health Advisory Board for the HLTH, or Health Foundation. In the past, he has served in a number of clinical leadership positions, including as department head of pediatrics at the Asian Health Services Community Health Center in Oakland, founding chair of the Immigrant Child Health Group of the American Academy of Pediatrics, and past fellow of the California Healthcare Foundation Leadership Program. In addition to this work, Dr. Choi serves as head of digital health at Samsung Electronics America, where he leads virtual care strategy and strategic partnerships. I'll introduce the other speakers as they come up, but just to let you know, we're also going to be hearing from Eleni Linos, Dr. Eleni Linos, who's director of the Center for Digital Health here at Stanford, and Fatima Rodriguez, who is an associate professor in the Division of Cardiovascular Medicine. But we're going to tee it up for Dr. Choi. Ricky, you're up.
Great. Just a quick set of disclosures. I work at Samsung Electronics. My comments represent my opinion and not those of Samsung. So, like many of you, I went into medicine because I felt like it was the most direct way that I could impact people's lives. But as I went through my medical education and my career journey, I quickly realized that I was really interested in broad scale impact. And so as an FQHC clinician, let me just get that screen off. I saw the many challenges to delivering optimal care, especially to those who needed the most help and felt like there were so many barriers. And so I concluded that healthcare was not going to fix itself. And so I started to look outwards. And I had noticed that I had patients who didn't even have enough money for Christmas presents, but they all had a smartphone. And even in 2015, it was becoming a requirement to navigate society, to work, to get housing, to go to school. They were using their smartphones to stay connected with loved ones, both local and abroad. And so, as Lee mentioned, I took a leap and I joined Samsung Electronics after 10 years of practice, which moved me and my family to Korea for that role, and then back in the United States about 4 years ago. And I continue to work at Samsung as my primary role. So, as a person passionate about health equity, working in industry has allowed me to gain some insight into how the opportunities and challenges for digital health to address health equity. And so I wanted to share some of those things today. And I thought maybe it'd be helpful to start with some basics, just because, with a couple terms. So what's digital health? And this is the definition that the AMA uses. Digital health encompasses a broad scope of tools that engage patients for clinical purposes, collect, organize, interpret, and use clinical data, and manage outcomes and other measures of care quality. It includes, but not limited to, telehealth, telemedicine, wearables, apps, and et cetera. And, this diagram from the National Academy of Medicine helps illustrate the fact that digital health has now become a part of many aspects of health and health technology, when we talk about environmental exposures and sensors to apps you may use to manage your chronic disease, to wearables you might wear to track your steps, all the way to track your stress or measure an EKG, all the way to diagnostics and et cetera. So really far-reaching in many ways. Now, I believe that the power and scale of digital health, can uniquely benefit marginalized communities and help close equity gaps. And in fact, digital access and skills are now being viewed as a social determinant of health, even a super determinant of health, depending on the situation. So when we think about the many challenges vulnerable communities face to get access to care, like transportation or taking time off work, or the long delays to get an appointment, you can see how tools like telehealth or remote patient monitoring could really help close those access gaps. Or instead of having a provider who can speak every single language in person in clinic, technology can help match a patient with culturally and language concordant care providers. And we know all the evidence that reflects the importance of that concordance and that language access. Digital health can democratize healthcare, where you can access data typically only available in a clinical setting, and give patients more power and more control over their health, so they can also detect disease states early. So imagine, for example, doing a pulmonary function test by blowing into a smartphone from home and not having to go to a clinic. And disease management apps can help to improve health behaviors and conditions that disproportionately impact certain communities, or who are particularly sensitive to environmental or other social determinants of health factors. So like asthma, for example, imagine then, you have an integrated experience where then you can tie in air quality into the action plans, or, diabetes management apps that are offer culturally specific diets and routines that make more sense for them in their routine. Or even in care delivery, where data analytics and AI can help detect previously missed patterns and signals in health data. Help with screening and identifying social determinants of health factors that can impact the patient. And you can also remind the provider, right, to discuss with the patients at the next visit or on a key area, or tying them in with the right community services. However, digital health today reaches a fairly narrow population, and frankly is not accessible to many underrepresented minorities. The scaling power of technology can expand opportunities, but can also expand inequity and leave people further behind. And in many cases, technology is built right on top of an already broken healthcare system, and so could very much scale those problems. And here are just some factors to consider, like affordability. I just mentioned before, even my lowest income patients had smartphones, but when we think about computers and data plans and et cetera, and think about technologies and benefits that rely on them, then, those sorts of things start to become out of reach, especially for people who need to kind of pay out of pocket. Or accessibility. We're all very conscious about health literacy and thinking about those things, but when we start adding in technology, then we have to start thinking about digital literacy. Do the patients know how to use that technology? Has appropriately training been set up, or do they have, culturally competent ways to get help, or even meet the needs with people with diverse abilities or linguistic barriers? Or product market fit. So, many of these technologies were not really developed with these populations in mind. In industry, we talk a lot about that minimum viable product, but that mentality also zeroes in on a very specific segment for the technology to be built for, with very narrow personas to meet and to fit the needs of a very specific demographic. So if they aren't included, marginalized communities are usually an afterthought. And so there's this overall lack of inclusiveness in product design, which then leads to efficacy, right? If these products and services are not designed for them, well, then will it work for them? Is there ongoing evidence creation on the effectiveness of the technology when used by marginalized populations? And of course, things like bias and trust. There's always a risk of inherent bias in technology. Does the sensor work equally well across different skin tones? Or for AI, for example, it's only going to be as good and free of bias as the data models it's built on. So if the data is entirely from a homogeneous majority population, then the results are flawed for the minority population. Is there an awareness about the bias in the system? Is there an intention to build trust with users, and et cetera? So there's a growing interest in this area. I know many academic institutions who are now, incorporating, these concepts around health equity as it relates to technology within existing roles or creating new roles in academic centers, but even in industry. We're starting to talk about that. And so we were using the term earlier, Techquity, the HLTH.org uses that term, and they define it this way: the strategic design, distribution, and availability of health technology to advance health equity. So it's a very intentional effort to try to avoid worsening the inequities and outcomes disparities as a part of how we build that technology and the data governance and the management. Let me just go quickly through 4 pillars, and for those of you who do participate, community participatory research, it'll start to sound very familiar, but in many ways, I think it's a new muscle on the part of industry. So first of all is building trust, establishing partnerships with individuals and communities, investing that time in that community, and adopting inclusive practices, engaging leaders, creating advisory boards, and et cetera, to keep them engaged, as well as hiring diverse talent within the team, so that it enriches the solutioning as well, and being very intentional about eliminating factors like stigma and bias. Or access to health tech. So, to build the right tech, we need to address the specific needs of the people in this community. We need to consider factors like affordability and increasing access to digital tools and technologies. Third is about supporting the initial use and uptake, and that's around that intentional inclusive design, incorporating feedback from target user groups, and bringing them in throughout the entire process, from identifying the needs, the ideation, the prototyping, the MVP, the launch, and then the ongoing iteration post-launch, so that we continue to stay true to the intent of that technology. And finally, enhancing sustained or long-term engagement. Is a lot of that, in my mind, is around effectively addressing the needs in a sustained way, and the overall health journey thereon, which may be unique to other populations, and those changing needs through user-centric design. So, there are lots of great ideas and concepts. So if we start thinking about practically, like, how does that look, right? And so I thought that this slide with this one particular image was going to be helpful in terms of getting some ideas about the kind of technologies that are being built. So Rock Health, for example, mapped out the landscape of startups using Medicaid and focusing on Medicaid, and identified 3 overall themes. And so the first one is around extending provider capacity. We all kind of know that one of the greatest needs for Medicaid enrollees is expanding the number of providers who see them. And so we know that only a subset of providers see Medicaid patients, due to low reimbursement rates and some challenges to getting payment. And so some of these companies are now building solutions to support providers by improving workflow, or helping providers address both medical and social needs together. And in other cases, for specific populations like children or pregnant people, serving as providers themselves. The second category is around optimizing enrollee engagement. So helping Medicaid enrollees understand and utilize the services and resources they qualify for. It feels like a little bit like some of the solutions that are out there to help people optimize the benefits from their employee compensation, et cetera. But using technology to scale up the community liaison on the ground, or offers to help with enrollment or re-enrollment or care coordination at community sites. And there are others working on housing or nutrition. And third, around data-driven insights. So it's about analyzing the population health data to improve Medicaid program design and incentive structure, understanding and tracking drivers of utilization and cost, identifying those most at risk of losing coverage and quantifying the social risk. And so to help this, Medicaid plans, as well as providers. So as a pediatrician, I can't move on without saying and talking a little bit about the needs of children. And children are often the most ahead in terms of technology, but ironically, the development of technology solutions for kids and health, we find that children are often being left behind. So as we think about the many ways that digital can drive health improvement, child health needs have really not been a focus, and we think that there are a number of reasons. There are a number of reasons why. The first one is that children and child and adolescent health is often looked upon as being a smaller market. Many of the technology solutions, developers are trying to meet the needs of payers and providers, and so helping them increases revenue to reduce healthcare costs. But while children represent 23% of the U.S. population, they only represent 10% of the health spend. So there is this kind of perception that there's just not a lot of spending there to reduce. We all know how underfunded prevention is, and a huge part of pediatrics is around prevention. And then regulatory hurdles. And so, there are increasing number of regulations and laws that protect health and data and privacy of children, as there should be. However, from a business perspective, those feel like things that are just going to add cost and time. And when given the option of another sector that may have lower hurdles, those start to look more attractive. Pediatric data management. We know that as children get older, the dynamics in terms of accessing patient portals by the parents start to change. It varies state by state, and can be weedy and still in some ways still being worked out. And again, adding more ambiguity in the case of a solution provider about what to build, how to build, and the paths to scale. We already mentioned the challenges with Medicaid. We know that 58% of the US pediatric care is covered by Medicaid or CHIP. We know the challenges around reimbursement and lack of providers. But if you add on the fact that Medicaid is a state federal program, it becomes very difficult to scale. So just because you have it all worked out for Medi-Cal in California doesn't mean you can automatically turn on that solution in that business model in Texas or New York. And sort of starts to become like a state-by-state game. Products for children are complicated because their needs change as they grow older. And another area that is sorely under-addressed, and this is both in child as well as adult care, is designing solutions that address the needs of multiple users at the same time. And so being able to have that user interface for both the parent as well as a child or a caregiver and the care recipient. So under the leadership of Lee Sanders, we in the Division of General Pediatrics created a task force to start to think about these things. We know that technology needs to be developed to address the needs and close equity gaps. We know that the needs of children are sorely underaddressed. And so we stack those two things together, that becomes even more challenging. And so we started to think about what is the role of Stanford to play in the heart of Silicon Valley to help try to move this ball along and to move this discussion forward. We put together this vision, mission, and principle and values. The vision is to lead the advancement of equitable child and adolescent health through digital solutions. And our mission is to promote the development, evaluation, usage of these solutions towards equitably addressing child health as we think about things like the triple aim or quadruple aim, family-centered care, and et cetera. And so we've started to go off to a number of areas of focus, thinking about the challenges around multi-user experiences, helping support the ongoing solutioning for children, as well as thinking about how do we create kind of a playbook in terms of engaging with Medicaid, state Medicaids, and so that we can unlock that approach towards for business to create solutions, and thinking about that user testing and design framework as we think about the needs of children. We've been really fortunate to have a whole host of partners, including Center of Digital Health here at Stanford, but also through partnering with the Digital Medicine Society, building a playbook with them, and engage with the Packard Foundation and Rock Health. We've been blogging as we've been thinking about the role of Medicaid in child health, but thinking about that from a almost a lifespan perspective as well. And so can look forward to continue to work in this area. So just really brief in conclusion, we know that digital health reflects this broad scope of tools to help improve health for patients and for providers. I feel that digital health unlocks a huge opportunity to address health equity in very unique and important ways. But there's still a lot of work that needs to be done when it comes to pediatrics. Thank you.
Thank you so much, Dr. Choi. We will now hear from Dr. Fatima Rodriguez. Dr. Rodriguez is Associate Professor in the Division of Cardiovascular Medicine at Stanford University and the Section Chief of Preventive Cardiology. Her research interests include a range of topics relating to racial and ethnic disparities, guideline adherence, personalizing cardiovascular disease risk prediction and prevention, and leveraging technology to improve the care of diverse patients. She has authored over 200 peer-reviewed publications and received the 2022 American College of Cardiology's Zipes Distinguished Young Scientist Award. She's also a two-time winner of Stanford's Alderman Award for Excellence in Clinical Research, the Department of Medicine Diversity Investigator Award, and the Internal Medicine Residency Research Mentor Award. Her work is funded by the NIH, the American Heart Association, and a number of other foundations. She serves as the co-chair of the National Minority Health Alliance and is a member of the American Heart Association Scientific Publishing Committee. So clearly, we're very lucky to have you here, Dr. Rodriguez. I'll let you take the floor.
Thank you so much, Dr. Sanders, and the organizers for this important webinar. So, the title of my talk is Health Techquity, and we're going to be some repetition around some of the concepts and definitions because I think they apply broadly. But my examples are more among the cardiovascular space because I am a cardiologist. And I'll also add that I am the Associate Director for the Center of Digital Health that is led by Dr. Linos, and she'll present next and just tell you a little bit about our development of that program and how health equity is really embedded in every aspect of the program and not an afterthought, which is a key, I would say, summary statement for all our presentations. Let's see if I can advance. These are my disclosures that are not relevant for this presentation. And today we'll discuss digital inclusion as a social determinant of health, some barriers and facilitators of health equity, and some great examples of how we can really use technology to improve cardiovascular disease prevention. So we all know that there's a clear social gradient in health. Whatever your socioeconomic metric is, whether that's income, education, social position, or occupation, as that gets better, in general, the overall health of the individual gets better. There's a really great example it's called the Whitehall study. That's a famous study of 18,000 British civil servants that shows the association between social class and mortality. And we can see here that in the British civil service, the highest class is the administrative class, and the lowest class as you go up to other. You can just see there's a very graded association with cumulative mortality. But even more interesting for me as a cardiologist is that when you looked at the traditional cardiovascular risk factors, what explained this excess mortality, it really wasn't just higher cholesterol, smoking, or blood pressure. A lot of the excess risk was unexplained. And the authors pointedly concluded in this study that a man's employment status was a stronger predictor of his risk of dying from coronary heart disease than any of the other more familiar risk factors, which we spend all of our time really tackling in clinical practice. And there's many, many examples of this. And this is just one example from Santa Fe, Mexico City. And this is an aerial view of the exact same location. So these are the same image. And you can see the different opportunities that people have to be healthy just depending on where they live. So very striking. And as we make recommendations for our patients, as we think about technology and digital access, we have to consider the built environment. A more local example from the San Francisco Bay Area, just 7 miles wide by 7 miles long, we can see that life expectancy across the city really varies by as much as 13 years. And this could be traced back to redlining practices. When we think about poverty and heart disease, you could essentially superimpose these two maps together. And again, this is true for many, many other chronic conditions. Work led by she's almost a graduate from medical school, Bongeka Zuma, showed that sociodemographic factors are actually stronger predictors of cardiovascular mortality for Black and Hispanic individuals. And again, a lot of the traditional risk factors. And also in this heat map, you can see that there's different areas where different populations live, and that could have significant effects in their cardiovascular outcomes. So we've sort of talked about it, but I just wanted to be very explicit about what are social determinants of health when we talk about it. The first that is often very ignored is neighborhood and the built environment, the conditions where people live, work, and play. Economic stability, and again, this can vary throughout the life course. Education, which tends to be more stable after adulthood. Sometimes there's protective effects around social determinants of health, and a lot of this has to do with social, cultural, community context and cohesion. And those protective relationships also need to be studied as well. And finally, access to healthcare. But I would argue that we spend a disproportionate amount of our time focusing on the healthcare setting and healthcare tools, and much less on the social determinants that affect most of the time where our patients live, work, and play. Digital inclusion is also a social determinant of health. And we think about what encompasses digital literacy and access, the technical skills, connectivity, access to different devices, applications, training and support across languages and education levels. It all very clearly intersects with all the other tenets of the social determinants of health. And again, a small amount of that has to do with the healthcare system. But as we think about patient portals, patient apps, wearable sensors, all of that is very closely linked with social determinants. So we heard this from Dr. Choi's presentation. So what is health techquity? So it's not just a cute buzzword, but it's really meant to be the intentional and strategic design, development, and deployment of technology to advance health equity. And we've heard this, but this really needs to be at the design stage of all interventions and not as an afterthought after a product is developed or goes to market. So now we're going to shift gears and talk a little bit about some barriers and facilitators of health Techquity. So barriers to health Techquity include things as simple as broadband access. And again, I'll show you an example of that. We take for granted that a lot of individuals own smartphones, but some things like the data plan that those smartphones may have, the access and the connectivity, and much less common are things like wearables when we think about Apple Watches or even those the rings that people wear to track sleep, and how complex are those apps that can work for them. There's also things around data privacy. We know that some of our population may be more nervous to use healthcare information in shared computer resources or in open public access computers. And of course, there's gaps in the product design for people from different backgrounds and educational backgrounds and social backgrounds as well. We just had last week, it was AI week at Stanford. There were some wonderful talks around AI solutions for healthcare. But as we think about the relationship between transparency, bias, and trust, those are really come up for particular most vulnerable groups, and happy to talk more about that in the Q&A. So this is one example of a study that was done showing the association between low broadband access and cardiovascular mortality in the US. And again, not surprising that a lot of the regions by state that have lower broadband access actually have higher rates of cardiovascular mortality. And this is even after adjusting for other traditional cardiovascular risk factors. There was a lot of excitement about telemedicine and actually getting more access to some of our patients for cardiovascular health. This is a study that was led at UPenn during the COVID pandemic that again showed that the switch to telemedicine actually exacerbated health disparities for older patients, women, non-English speaking populations, and lower income patients, and that you really had to be intentional in this or it would further the digital divide. When we looked at our own data in our Stanford healthcare system, we found that although many groups switched to telehealth, there was actually much less use of different types of telehealth. So in specific, video visits were much less common for patients who had non-English language preferred. And if we think about what may cause this, it's just the additional steps and the additional resources that may be required to instruct someone to log into a video platform and have that connectivity available just wasn't as common. So a lot of these visits for the non-English language patients were actually switched to phone visits, which again may have less information. So what are some facilitators of health Techquity? There's a lot to be discussed here, but this is actually a really nice summary from a diagram of McKinsey and Company showing that some of the steps include considering historical context, and that explains a lot of things around trust in healthcare, address unmet needs, and you really need to personalize it. There's not going to be one app or one solution that works for everybody. So you have to design to meet those individuals who you're trying to help, and they need to be part of that conversation as an initial stakeholder. Of course, access to healthcare is paramount. If you're giving somebody a digital tool to help control their health, what do they do with that information? Is there somebody else on the receiving side that can help tailor interventions or guide preventive care? Again, we are all discussing this, but the importance of partnerships and bidirectional learnings to enable equity, embed health equity into the development and design stage. And again, for things like AI that are iterative, it has to not just be at the beginning, but throughout the life course. And again, Dr. Choi mentioned this, there's so much importance to building a diverse and inclusive team because people from different backgrounds can pick on each other's blind spots and really help us not miss things for different populations. So now in the last few minutes, I just want to give you some examples of what I consider some good interventions in cardiovascular disease prevention that leverage health Techquity. One example that our group has been working on has been using artificial intelligence for opportunistic screening of cardiovascular disease. As a preventive cardiologist, I spend a lot of my time trying to identify what type of patients are at highest risk of heart disease. And sometimes we rely on a specialized type of heart scan that is gated to the beating heart. But these type of scans actually cost some money out of pocket. It's a small amount of money, but for some populations, it's really cost prohibitive. And again, this requires somebody to be seeking cardiovascular disease prevention. Because insurance companies do not cover these scans, and again, there's an access issue, we know that certain minoritized populations and groups are going to be left out. So what we did is that we partnered with a great group called Bunker Hill to develop an algorithm to quantify the amount of calcium in the arteries of the heart on non-specialized CT scans that are really done for other reasons other than to assess heart disease risk. This would allow us to identify a much more diverse population that may not know they're at risk of heart disease and then bring them into preventive care. When we notified patients of the presence of coronary calcium, we found that over 50% of them started statin therapy to reduce their risk. And again, this is in contrast to very low levels of starting statin prescriptions in usual care of only 7%. People also started engaging more around controlling cardiovascular risk factors, including having their blood pressure controlled and seeing their doctors more for preventive care. And that at 18 months after the intervention, we saw that actually the effect size still lasts and people were able to adhere to their therapy longer term because of the personalized, artificially intelligence-enabled creation of this algorithm. This is a program about remote disease management for improving cardiovascular health led out of the group at Boston by Mass General Brigham. And what they did as part of their digital care transformation program is that they created remote algorithms to manage cardiovascular risk factors for improving cholesterol and hypertension control. And this was all led by non-physicians. So it was pharmacists who were initiating and titrating the medications, following clinical algorithms. And the take-home point is they found significant and sustained reductions in cholesterol and blood pressure. But much more exciting was that this was seen at similar rates and improvements across all races, ethnicities, and language preferences. And I thought that was very notable because that was intentional in the design stage. When they designed this completely remote workflow, they made sure that there was flexibility in how patients could communicate with the pharmacist. And this included for some people just something as simple as a text message or a phone call or emails, and they were flexible. And I think that's really an important lesson as we design with health Techquity in mind. And there was also multilingual processes to expand patient reach. And again, these investigators in the design stage wanted to make sure that the patients who would benefit from this intervention are the ones who are most affected by the conditions of high blood pressure and high cholesterol. And finally, I thought this was a great study called the Step It Up app, which was a digital health intervention designed to address barriers to physical inactivity in low resource communities, primarily for Black women. And what they did, you can see here some examples, that they helped individuals find safe areas to exercise outside, and again, with personalized text messages and engaging. And then this was studied in a rigorous randomized controlled fashion and found that when you tailor the messaging to place where people actually live, people had more steps per their day. There was greater engagement, especially when they consider factors around neighborhood social cohesion and neighborhood safety, which again, may be things that we miss out when we design these tools. And the final point I'll make is that sometimes when we talk about precision medicine and data, we may think it's at odds with what we're really trying to do with health equity with more of a public health lens. And I would say that that is not the case at all. That the only difference is that for precision medicine, we focus on really a small number of people getting a lot of personalized data. But for public health and precision public health, we just need to use all the large amount of data that's available, not only from the patients at their clinical encounter, but also around the built environment, and use that to make better decisions that affect not just one person, but entire communities. So in summary, digital inclusion is a social determinant of health and is really required for considerations of health Techquity. Digital health interventions must be tested and rigorously and intentionally. So some things seem like a good idea, but it may not work the same way for every population. So it's really important to not lose the rigor that we have in academic medicine to really test interventions, especially if we're going to invest resources in those technologies as health systems. Artificial intelligence is really a promising tool for opportunistic screening for heart disease and many other conditions that may be missed in routine care. Virtual care models may provide scalable solutions to improve population health, and this is really necessary for the common cardiovascular risk factors that we deal with every day. And importantly, digital health interventions must prioritize health equity in the design stage. Thank you so much for your attention, and I look forward to the Q&A.
Dr. Rodriguez, phenomenal tour de force. That was wonderful. We're next going to hear from Dr. Eleni Linos, who is director of the Stanford Center for Digital Health at Stanford. Her work focuses on the use of technology in health, dermatology, public health, cancer prevention, and the care of older adults. She's dually trained in epidemiology and dermatology, several NIH-funded studies. She received her MD from Cambridge and Oxford universities in the UK, then trained in epidemiology at Harvard, before finally coming to the West Coast and settling in as in her residency at Stanford. We're so proud to call her a colleague here.
Thank you, Lee. Thank you for the kind introduction. And today I wanted to talk a little bit both about my professional journey and some research related to equity and technology, and tell you a little bit about the Center for Digital Health that, as Fatima mentioned, she's one of the associate directors of, and I'm the director, so we work very, very closely trying to lead the Center for Digital Health in this direction. So I think I will share some slides briefly. One second. Let's see. Fatima, will you tell me if you can see them? All good? And
Yes,
you can
we see them.
Okay. So about a year ago, I took on leadership of the Stanford Center for Digital Health. And really delighted to tell you a little bit about what we're building, and also tell you a little bit about my journey as well. So first of all, I have no financial conflicts of interest. But overall, throughout my career, my goals have been really focused on conducting research on how to apply technology wisely to ensure inclusive and equitable care, while at the same time inspiring and training the next generation to care about not only the content and the scientific validity of our research, but also the impact of our research. And so briefly, I'll show you some pictures of my family. These are my parents and my sisters. I grew up in Greece, and to a family of physicians. My parents were both physicians. My mom was an epidemiologist. And the four of us that you can see in the 80s have now all turned out to be academics in different fields. So my sisters are professors in law, public policy, and public health. And so I have this little family think tank, and my mom's leads a nonprofit focused on refugee and minority health in Greece. And so, I have always been raised with this underlying value of helping everyone, especially those who need more help. So that's been kind of fundamental in who I am as a person. I also want to acknowledge some of phenomenal mentors I've had throughout my career, both for my PhD, my junior faculty years, both here and at Harvard, where I trained, who instilled, again, not just the value of doing very rigorous, excellent scientific research, which obviously we know as academics at Stanford is fundamental, but making sure that when we do this research, we're always considering the implications to populations, especially vulnerable populations. So my scientific path has been that of a traditional physician scientist, tackling research questions, again, that have an impact on people's lives. But I've always tried to focus and think almost for every study, how can we adapt this study to focus on reducing disparities and improve the health of vulnerable populations? And I'm very, very passionate about science communication and try to answer these problems with creativity and perseverance. So I'm a dermatologist clinically, but my research has always been at this intersection of technology, public health, and dermatology. But because I get distracted easily, we've also published a lot on geriatrics and aging, again, with a focus of not leaving anyone behind, not leaving older adults out of the conversation about technology. Also written a lot about mental health, gender equity, especially the needs of academic mothers and academic women in medicine and cancer. And so here I just briefly want to mention the Center for Digital Health that Fatima and I co-lead, and tell you that we're in this process of relaunching and growing this center. The center sits in the Department of Medicine and has for several years, and we are just delighted to be expanding its impact. Our mission is to bring together the best and the brightest minds of Stanford, Silicon Valley, and the world to answer the most pressing research questions in a way that is scientifically rigorous and ethically sound. And our role is really threefold. One is to be a convener and foster collaborations with innovators through CDH events and team science. To be a catalyzer of research, so research that wouldn't otherwise happen by offering seed pilot grant funding that I'll mention in a bit too, and to be a thought leader. So far in the last year, we've awarded $250,000 in pilot grants. We have several faculty affiliates, scholars, digital health scholars who are junior faculty joining our team. And we've hosted an annual conference that included over 200 participants for 23 countries. And we're planning for the next one in October. We'd love all of you to be there. And here are some photos for some of our pilot grant events, our seminar series. We're also launching an industry affiliates program to try and partner with industries both in the Bay Area and internationally on this endeavor. And here's the one announcement I wanted to make for this group. We just launched our 2024 cycle of pilot grants. These are one-year grants of $50,000, and we encourage collaborative proposals that bring together investigators from different disciplines. And one thing I wanted to mention to this group is that we've explicitly stated in our instructions for these awards that proposals that focus on reducing health disparities are encouraged and will be prioritized. So trying to, even when we incentivize research, to have this idea of equity and reducing health disparity right in the call for proposals for research. Always, it's wonderful to build things in a team, and this is our incredible advisory board that spans leaders from the worlds of academia, technology, and have really been incredibly helpful in guiding our center in this early phase. And also delighted to introduce you to our team. We're just joined by Michael Avanti Lopez, who is our executive director, and Maya Adam and Fatima Rodriguez, as well as you and Ashley, are our associate directors. And Lara and Nina, our program manager and program lead, you may hear from, who basically run the show for us day to day. We're also engaged in a strategic planning process with the Dean's Office right now to align the CDH's mission with the university and Stanford healthcare as a whole. And I might pause there. Lee, you asked me to share a couple of examples of my research, which I could do briefly, but I know it's 12:45 and we want time for Q&A, but happy to talk about studies on gender equity, on skin of color and dermatology, on telemedicine, on the use of technology for older adults. But we can do that in the Q&A. Thank you, Lee.
Eleni, why don't you start off by sharing, some examples of technology advancing equity?
Sure. And Lee, I feel like your seatbelt, I think I heard you say some examples. So maybe one I'll start with is, we've done some work within dermatology to try and ensure that as we build image libraries for AI, for analysis of skin disease, through computer vision techniques, those images are representative of all skin colors and skin types. And this is the work led by colleagues at UCSF, including Dr. Jenna Lester. But also we've tried to continue that work here as well. We're currently doing an R01 funded study to try and collect images from older adults, again, making sure that when we design technological tools, they're designed for every age group. And so that's been really fun for me to do, to try and adapt and develop tools that are really accessible and useful to older adults. Fatima, I don't know so I'm a little worried that Lee might not have good reception. So should we?
I'm
Okay.
still on. But I think we should look at a couple of the questions in the Q&A.
Okay.
There was a specific question for Fatima, for Dr. Rodriguez, about AI screening of the
Oh, yeah.
CT.
Great question. So we have a whole set of projects, and I just kind of briefly shared with you as an example because it's opportunistic screening. So it depends, and it depends. We have some projects we have an IRB, so there's a waiver of consent in that way. But these are all within standard of care. So all these imaging reports actually already contain documentation. There's presence of coronary calcium. What the AI algorithm is doing is able to screen large numbers of these and then make recommendations for healthcare. But yes, there's in our focus groups now we're talking to our patients. There's always concerns around like data privacy and what you're using for, and of course it could only be used for the quality improvement project specifically that we have approval for, or for the IRB guided research. So people can't just do this, just use it for no reason at all. And that's a really important question, and one of the things that our patients really worry about when using AI tools.
Thanks, Fatima. And I can see the questions right now. And I don't know, Ricky, if you want to take some of these about designing, for equity from the beginning. How do we get the resources to do this?
Yeah, I think that, no, I think that it's really important. I think that to me, it always starts with understanding the need really well, right? We need to understand what's the problem we're trying to solve and how is it unique in particular for this particular community. And then depending on what your goals are, if your goals are specific for health improvement for that particular group and it will be stay within the hospital, or if there's an intent to go to market and to sell this broadly so that you can continue to grow that solution such that it can affect and improve people's lives, those more and more people's lives in other groups. I think those start to play into how you make choices about where to put investment in. But I think that starting point, understanding the need really well and having diverse teams is really important. I just saw this one other question around, health technology and reducing health disparities for vulnerable populations. I just wanted to offer one other example. For the HLTH.org, they did a spotlight and did some awards for some startups who are focused on addressing health equity or Techquity. And one of the companies they mentioned was this company called Backpack Health, and I just thought it was a nice example. As we know, those in child health know there's a huge lack of mental health providers in the pediatric space, and it's been that way for a while. But during COVID, I think it really started to not only become a bigger problem, but the broader awareness also grew as well. And so this startup called Backpack Health has designed a solution where they deliver mental health counseling, education, and programs in between sessions for patients specifically on Medicaid. And they've enabled technologies to help them with interpretation and to get cultural concordance along that as well. It's founded by a minority immigrant woman who during COVID was surprised to discover that one of her children was having suicidal ideation. At that time, she was in between jobs on Medicaid and couldn't find a provider. So, some of these solutions, I think that Medicaid is becoming an object of interest for a lot of for-profit companies, which and I think that that will continue to grow as entrepreneurs try to find like white space in areas that they could try to innovate around.
I was just going to ask that I think it's really important what Ricky said, like that a lot of times we just get the technology, and I have many examples of that, and they're like, use it. And that's the wrong way to start. You want to start with what problem are you trying to solve? What is the need that you have? For us, is it that we're picking up people with heart disease much too late when they're coming in with heart attacks. So that's the problem that we're trying to solve. And those individuals tend to be from populations who don't seek preventive care. So can we pick them up more upstream where the solutions are much, much easier? But again, they depend. And it depends. And I think there was a really good question in the chat about there's so many of these technologies around subspecialties. Who does this fall on? And yes, I completely agree that this is not right to put this on the primary care doctor. There's so many other demands on people's time. So that there should be like the Brigham remote pathway or the Mass General Brigham, that is independent of the primary care doctor. And it doesn't have to be, but again, we can't keep asking our primary care doctors to do more and more without having the tools to do that efficiently.
Yeah, I think that's great. And Dr. Linos, I don't know if you feel like you addressed this yet. There's a great question from one of our guests about it's essential to design equity from the beginning. How do we get the resources to do so? And should there be suggested guidelines? For example, if it interacts with a certain part of the human body, like skin, don't apply it until it's accurate for some minimal proportion of the population. Seems like that's right up your alley.
Yeah, I guess designing for equity from the beginning is really important. I noticed, I don't know if it was the same question, I can't see it now, or another one that said designing with diverse communities rather than for. And I guess one fundamental thing, which, it's kind of obvious as we try to train the next generation of leaders and scientists, is making sure our own research teams and are diverse, because I remember learning this early on in my career when we were doing, a lot of my early research was on the harms of indoor tanning, of tanning beds. And particularly, there's very high tanning bed use and higher skin cancer rates among gay men. And I remember being in a focus group that I had designed, trying to understand the barriers and why gay men use tanning beds and don't get as much skin cancer protection and screening. And, quickly realized I had a student with me who also identified as a gay man, who was sitting in the back, and I was leading the focus groups, and no one was talking to me. This was a focus group of gay men. And as soon as he started asking some of the questions, I realized the whole group of participants and patients opened up. And actually, that was for me a really early example of, like, I really shouldn't have been the person, the scientist leading that focus group. And as soon as we switched roles and I was in the back taking notes and he was leading the conversation, we learned so much more. And this, led to a scientific publication and lots of interventions based on this work. And the same is true when we're designing, we're trying to design materials to promote whatever it is, COVID vaccination, cancer screening, to Hispanic communities in the Bay Area. Again, who is involved in the design and who is involved in the planning of the research study is really important. So this ties very well, not only in prioritizing the target population, but also prioritizing who the team is, who the mentees is. And it kind of ties in very nicely with our goals for medical education and, the selection of who the best people we want to train and be part of our scientific workforce. I don't know if that answers your question, but
I hope it does. We're getting the questions to the Q&A. Please add other questions. The next guest asked something related. I think I might throw this to you, Dr. Rodriguez, first. With so few BIPOC, Black and Latino physicians, what are some initiatives that you're doing or aware of to include minoritized communities at different levels? So Dr. Linos just talked about, the nothing about us without us sort of framework in health equity and community-based participatory research, but also on the design teams. So anybody can comment on that, but maybe Dr. Rodriguez first.
Yeah, I can certainly just put something on the chat of a really great example from one of my colleagues at Mayo Clinic, Dr. LaPrincess Brewer, who has a whole program around using faith-based interventions to try to improve heart disease risk factors. And she'll tell you this community-based participatory research is hard work, and it's not for everybody. And you have to do the investing in the community before you come with an ask. So she said for 2 years, you're just getting to know the community and building the trust. You just don't come and say, hey, we need you to be part of this research study. Now, it also is partnering directly with the communities for whatever it is that you need to do. So you don't come in and say, I want to lead this project. You say, who in the community is the right person to lead this project? There's some Stanford IRB kind of issues around that it's like a whole other discussion that hopefully we can streamline down the line. But I'll get back to the investigator diversity piece. That's really important. And I know we see it in our research teams. Who are we training to be a clinical, in my work, like clinical trialist or clinical investigator? And there are programs for that because we just know that patients, communities are just much more comfortable depending who the messenger is. And not even at the physician leadership level, but also at who's delivering the intervention. If it's a community health worker, if it's a nurse, all that concordance is very, very important. The final thing I'll say about that you have to approach all community relationships and patient design aspects with humility instead of competence, and saying, this is what you need. Like, I know you need to reduce your heart disease risk. Like, I may say that because in my mind that's important, but that may not be the most important thing for that community. So I think is understanding what they prioritize and then aligning the priorities together, because I bet you they're very different from what we think they should be.
Great. Well, that's perfect. We only have a couple minutes left. I want to acknowledge a question that I'm going to give you each 1 minute to tie us up. There was a question, if you want to address it, that the DEI initiatives, that is diversity, equity, inclusion initiatives, are under attack globally. How should this be handled, particularly at medical school levels, if you want to take that on? But any other last words of wisdom, particularly around this question around guidelines or guidance for this work? I know Dr. Rodriguez and I were in a lot of those meetings. I think Dr. Linos also last week, about guidance for how to do this with AI ethically and equitably. So Dr. Choi goes first, then Dr. Rodriguez, and Dr. Linos. Any of this?
Those questions are way too hard for me, so I'm going to bypass it completely and just say just 2 points. One, I think that, you know, maybe it's because we're in pediatrics, we see a particular demographic a lot, right? The parents that we're seeing delivering babies are now, you know, millennials, or the 30s and, you know, 20s, 30s, 40s. You know, their children, Gen Z, et cetera. They're all digital natives. There is an expectation now to receive health and healthcare in a particular way, much like the way that they're used to traveling, using Google Maps and Yelp and Discord and all those sort of things. If it's not there already, it's coming. And so we need to be able to do that well, and of course, align to our mission in terms of with health equity. And then the second point is that I just encourage everyone to continue to think about where there are these big gaps, where there's a lot of health inequities. Digital can uniquely benefit them. And I saw that in my FQHC every day. But we have to make sure we steer the ship and make sure we're pointing at the right problems, so that we can actually make the most of that. Thank you.
Yes, and I think the questions you had are very tough to tackle in 30 seconds. So I'll just say that it's not about diversity, quote unquote, for a checkbox or for diversity's sake. Diversity equals excellence. Like there's no and I think industry actually leads this better than we do in academia, because you know that more diverse teams, and again, diversity broadly defined, lead to better solutions. So it really is the answer. And I'll say that there are great examples that we're all happy to share around opportunities for improving equity with technology. I'll say in the pediatric space, the type 1 diabetics and the continuous glucose monitor, the pediatrics group just put out a great group on that. But again, these are clear tech-enabled solutions of how we can help our patients control their chronic diseases. But we have to think about, you know, who's getting the glucometer? How are we getting them to them? How are they? All these kind of like logistic things, not just like it's a great solution, but how do we physically? I mean, think about the complexity of so many things we do in medicine. And the definition of equity is not making everybody a little bit better. It's giving the resources, aligning those resources with the amount of need. And I think that definition is not clear to most people and most healthcare systems.
And
Last but not least,
for at 1:01, and I like being on time. So I just wanted to say that it's just an honor to be part of this group and to even be discussing and thinking about these issues. We're so lucky to be at Stanford, to be able to talk about these issues and to study these issues, that we have resources and funding opportunities to continue doing this work. So it's just wonderful to have such amazing colleagues here.
I echo that, and I just do want to close with a great round of gratitude to Dr. Ricky Choi, Dr. Fatima Rodriguez, and Dr. Eleni Linos for joining us for this Techquity webinar. Sounds like more to continue in the near future. Thanks, everybody. Take care.